At a first glance, this chest X-ray may appear scary to you, since you see a focal opacity in the left lung apex. Let's stop here and look at a normal case before that, since this is a good opportunity to review some of the basic concepts on chest radiograph for juniors. Here's a normal case for comparison. The first observation is that the heart and mediastinum are in the center. The second observation is that in most cases, the right hemidiaphragm is higher than the left hemidiaphragm. A third observation is that usually the left hilum is slightly higher than the right hilum. We know that the right lung is composed of 3 lobes versus the left lung, which is composed of 2 lobes, which makes the right lung normally slightly larger. Another thing you may notice here is the space in between ribs. This is the posterior rib here and the other one below it. And the space here, the intercostal space, seems equal and symmetric to the intercostal space on the left side. So to summarize, in normal cases, the heart and mediastinum are well centralized if you allow for the minimal left-sided location of the heart because of the apex. The right hemidiaphragm is typically higher than the left, and the left hilum is typically higher than the right. The right lung is usually slightly larger than the left lung, and the intercostal spaces should be symmetric on each side. So let's go back to our abnormal case and see if we could apply the rules that we just learned to make something out of it. As agreed before, there is an opacity in the left upper lung. However, other findings are also noted. The first observation is that the mediastinum, as denoted by the tracheal air column, is deviated to the left side. Along the same lines, the cardiac shadow is significantly deviated to the left side as well. There is also substantial elevation of the left hemidiaphragm, especially when compared to the right side. It's difficult to compare the left and right hilum because of shift of structures. However, if you look at the airway, the left hilum is significantly elevated more than usual. More so, although we agree the right lung is larger, but this is significantly larger to what looks like a smaller than usual left lung. A neat observation is to see the differences between the intercostal spaces, and you can see how the ribs are more crowded here, leading to a smaller space on the left. So putting all these findings together, this is a case of volume loss on the left side, which you could also call collapse. Collapse or volume loss may be complete or partial and may be acute or chronic. The best way to identify volume loss is to look at structures that shift from their position or a decrease in size of the hemithorax or intercostal spaces. Although outside the scope of discussion for juniors, seniors may have noticed that this opacity has a linear, irregular component, and that there are air-containing lucencies that appear elongated or linear within the area of abnormality, suggesting bronchiectasis. And what appears as a scary mass is rather an ectatic atherosclerotic aortic arch that's displaced to the left side. The general rule is that you should not miss collapse, since in adult, collapse may represent compression of a bronchus by lung cancer. However, in this case, the features that we see are suggestive of a chronic nature with some scarring and bronchiectasis. And when this was compared to a chest radiograph about 3 years ago, the appearance has not changed. So the overall diagnosis in this case is chronic scarring and bronchiectasis with total volume loss in the left upper lobe, which is likely secondary to an old insult such as an infection, and in our region this is commonly related to old TB. And to continue the case, this is confirmed on the coronal CT image as total loss of the left upper lobe and internal bronchiectasis. So this was a case of total volume loss of the left upper lobe due to a chronic insult with associated internal bronchiectasis likely due to old TB. The most important teaching point from this case is to look carefully for signs of collapse or volume loss. One of the concerning causes of volume loss would be an associated neoplasm compressing an airway. For you not to miss collapse, make sure that the mediastinum, heart, hemidiaphragm, hilum are in their normal positions. Assess the size of the right lung and hemithorax compared to the left, and make sure that there is no asymmetry in the intercostal spaces. Thanks for watching. See you with more cases later. This is a CT of the abdomen without intravenous contrast, showing this abnormality within the musculature of the abdominal wall. There is enlargement of the left abdominal wall muscle compared to that is atrophied on the right side. If you follow the muscle from above below, you'll notice that this muscle is actually the rectus abdominis muscle. The internal density of this abnormality is that of low density with areas of rounded high density. Note the presence of fat stranding in the adjacent subcutaneous tissue. The fat should look clean as you see here, and it's not in this region. So before jumping to the conclusion of this being a primary sarcoma of the muscle or secondary metastasis, think about the described features. The internal expansion of the left rectus muscle with the fluid density and these foci of high density in addition to the stranding is suggestive of hematoma. Remember, blood clots on a non-enhanced study may appear bright. Although rectus sheath hematoma may be related to trauma, it could be spontaneous, especially in patients on anticoagulation. So this is a nice case of acute hematoma in the left rectus abdominis muscle that should not be confused with malignancy. We know such an abnormality may be spontaneous, and from an imaging point of view, blood on a non-enhanced study may appear bright. Thanks for watching. More cases later. The reason I'm showing this case is to concentrate on this abnormality here. Let's talk a little bit about some anatomical considerations before we proceed. Let's look at another normal patient. We learned that CSF spaces are very dark on a CT scan of the brain. We also know that this is the ventricular system, and this part of the ventricle is called the lateral ventricle that you see on each side. This central slit-like area of CSF density here is the third ventricle, which communicates with each lateral ventricle through those. These two foramina are called the interventricular foramina of Monro. So the highlighted foramen of Monro connects the lateral ventricle with the third ventricle. Now that we understand this piece of information, let's go back to the abnormal case. For the junior follower, we learned before that high density on non-contrast CT could be calcium or hemorrhage. The density of this area is less than that expected for calcium, especially if you compare that to bone. The fact that this is isolated in this location and hanging there would be very unusual for free-flowing hemorrhage. If this was indeed interventricular hemorrhage, you'd expect to see hemorrhage dropping elsewhere within the ventricles, especially in the dependent locations. So if this is not hemorrhage or calcium, what is this? Our senior followers have probably figured this out. This is a classic appearance of what we call a colloid cyst. A colloid cyst is a congenital benign cyst that classically occurs in the ventricle exactly at the region of the foramen of Monro. Such cyst may be symptomatic if it grows, if it's large, or if it's mobile secondary to obstruction of the flow of CSF and related hydrocephalus. The location of this abnormality is so classic. Now the color of a colloid cyst may be low, high, or intermediate. So on a CT scan, the colloid cyst may be iso, hypo, or hyperdense. So for the seniors, I'm showing the MRI on the same patient to highlight a very important point. Although a small colloid cyst is an important finding to detect. It might be very difficult to see on an MRI acquisition. It's not an abnormality that jumps at your face when you look at an MR unless you look carefully at the midline structures. And it might be confusing since we know that you could have CSF flow artifacts in such locations. So this is the flare acquisition. This is the T2 acquisition. And this is your susceptibility weighted image. Again, very difficult to detect on MR. So back to the CT scan. As much as 50% of colloid cysts are of high density due to proteinaceous or hemorrhagic components. So we learned from this case an important anatomical location, the foramen of Monro that connects the lateral with the third ventricle. We learned that we need to look carefully at midline structures, especially on MR, where some findings may be difficult to detect. We talked about a congenital but a very important abnormality that's called a colloid cyst with a classic location at the foramen of Monro. We learned that colloid cysts may have various colors on CT and on MR. Most of them are hyperdense on CT due to protein or hemorrhage. From now on, we have to look for these carefully since such a lesion may lead to fatal acute obstructive hydrocephalus. Thanks for watching. More cases later. This is a CT angiogram of the aorta. As you see, there is contrast that's very bright within the aorta, and that's the way these studies are done. The aortic lumen, which is here, should be of uniform brightness. So this appearance is extremely unusual. We know that the internal part of the aortic wall is called intima, and what you see here is a displaced intimal flap that runs within the lumen. This intimal flap divides the aorta into two lumens, one which is false and the other which is true, and this is an aortic dissection. There are several ways of differentiating the true from the false aortic lumen. One of the more reliable ways is depending on the size, since the false lumen is usually larger. Another thing to look for is internal linear material, and this results from shredded connective tissue from displacement of the intimal flap. So if you see internal strands within the lumen, that suggests that this is the false lumen rather than the true lumen. Now, aortic dissection is typically a result of hypertension. Risk factors for dissection would include aortic aneurysms and connective tissue disorders such as Marfan syndrome. If you inspect the intimal flap carefully, sometimes you see these defects, which may be the entry point where the dissection initially happened. Dissections are classified into two types, a classification called Stanford classification. If you take the aortic arch branches from proximal to distal, you have the brachiocephalic artery here, followed by the common carotid here, and finally the left subclavian artery. So brachiocephalic, left common carotid, and left subclavian. The left subclavian artery is an important landmark that's going to help us divide our different types of dissections according to the Stanford classification. Any dissection that involves the aortic root, the ascending aorta, or the aortic arch all the way to the left subclavian artery is called a type A. A dissection that is isolated to the descending aorta, so isolated to the segment after the subclavian, is called a type B. To memorize this, type A, any involvement of the arch or ascending aorta. So A, arch or ascending. Type B, which is isolated to the descending aorta, could be memorized by beyond B, beyond the subclavian. Now, why is this important? This classification has implication on patient's management. Type A dissection is associated with major complications that lead to morbidity and mortality, and that's why this is an immediate surgical emergency. So type A could extend into the aortic arch vessels. Here it extends into the subclavian, but this could also extend into the carotids and gives the patient a fatal stroke. Now, another thing that could happen with a dissection is that it could extend inferiorly into cardiac structures. For our senior followers, have you noticed that this dissection actually does that? It extends all the way down, and this is a thrombosed false lumen, so this is a very serious case. For juniors, this is a coronary artery that arises from the aortic root. This is another coronary artery that arises from there as well. So such a type A dissection could extend into the coronary artery, and that may give the patient a fatal myocardial infarction. As we learned from a prior snap, this is the pericardium, and the dissection may extend into the pericardium and give a hemopericardium. If such a pericardial abnormality compresses or restricts the cardiac function, this is what we call tamponade, and this may be fatal. An additional complication is extension into the aortic valve. These are the aortic valve leaflets. If they are involved, you may have aortic regurg. And severe aortic regurgitation would affect the left ventricle in a way that could lead to heart failure, and that may be associated with high morbidity and mortality. Finally, an aortic dissection that extends into the pericardium may give the patient fatal arrhythmias. So due to stroke, MI, arrhythmias, tamponade, acute aortic insufficiency, this is an emergency that needs to be treated now. So this is a type A dissection. However, if it's a type B that is isolated to the segments of the aorta distal to the left subclavian, the treatment is different. Treatment for type B dissection could be performed on conservative basis by admitting the patient and treating his hypertension. However, for seniors, not all type B dissections are treated conservatively. There are exceptions to this rule. For seniors, I will dedicate another snap in the future for discussing these exceptions. I will also dedicate a future snap to talk about more specialized points regarding dissections. Now, to complete the case, you probably noticed that the dissection extends all the way inferiorly as well through the descending thoracic aorta. This is a part within the descending aorta where the false lumen is partially thrombosed, and it also extends into this vessel here. This is the superior mesenteric artery. If you go higher above, you'll notice that the celiac artery arises from the false lumen. Continuing all the way down, you'll notice that the common iliacs are involved, especially the left external iliac, which is totally occluded here. Again, this is the occluded external iliac. It goes all the way here and then reconstitutes again in this location within the inguinal canal. Seeing such vascular involvement, it's easier to understand that dissections could lead to bowel ischemia or limb ischemia as well. To summarize, aortic dissection is a complication of hypertension, connective tissue disorders, and aneurysms are risk factors. Left subclavian artery to divide the dissection into type A versus type B. Any involvement of the aorta proximal to this vessel is called a type A that has to be treated immediately by surgery or by endovascular approaches. Involvement distal to that is isolated to these segments, is called a type B and could be conservatively treated. Remember that type A dissection could be complicated by stroke, myocardial infarction, arrhythmia, pericardial tamponade, or acute aortic insufficiency. Finally, make sure that you look at the dissection carefully, because the false lumen could be thrombosed, such as we see here, and you might miss such an important extension of the abnormality. So this is a type A dissection. Thanks for watching. See you with more cases later.